Hello and welcome to the Pypecast, Acute Coronary Syndrome, and in particular the medics protocol associated with the acute coronary syndrome. So we will be delving into the PCCM a little bit and be using it as our reference, but more so we're going to go through a lot of physiology, pathophysiology, pharmacology of the actual treatment of acute coronary syndrome. So just to start off, as a means of introduction, acute coronary syndrome happens when the cardiac muscle is in danger. When the cardiac muscle requires more oxygen than it's actually getting, it starts to go through physiological effects in changes which can result in its death. Now, once the myocardium is starving of oxygen and ischemia has begun to kick in, you have a period of time in which the necrosis is going to become irreversible versus your reversible necrosis. Now, the general rule of thumb is about every 30 minutes of myocardial infarct, you have an increased mortality rate of about 7.5%. So the big take-home message for this one is if you believe somebody has myocardial infarct or is suffering from acute coronary syndrome, or has signs that their myocardium is starving of oxygen, then you need to implement treatment quickly, and evacuation is an absolute priority. So just to bring it right back to the absolute basics, we'll look at the pathogenesis of acute coronary syndrome. Now, most of the time when we're dealing with acute coronary syndrome, we're talking about the build-up of plaques, and in particular vulnerable plaques that are caused by an increase of atherosclerosis. Now, atherosclerosis is caused by a number of different variables, and we'll talk about the high-risk population soon, but the variables start generally with fat smears. So most of us, being in the Western world and the way we live, we will have fat smears lining on our actual arteries themselves. Now, these fat smears are a result of LDL cholesterol that just get stuck and bind to the endothelial wall. Now, from there, we have physiological changes underneath the arterial wall lining. This is where we get the inflammation of T lymphocytes, monocytes, and your foam cells will actually come into the area and they'll actually build up and therefore decrease the lumen of that particular plaque. And most of the time, the sheer presence of atherosclerosis isn't a problem. You need about 75% occlusion before you actually start feeling symptoms, so it's quite late in the day. But if those plaques are vulnerable and if the condition of the person is conducive to endothelial damage, then you'll end up getting plaque disruption. And from the plaque disruption, it will cause an increased probability of causing thrombosis. Now, thrombosis is caused by a number of different factors that we'll talk about, but one of the ones associated with endothelial damage is the fact that collagen fibers will actually break out into the vessel, allowing platelets to connect to it and then encourage platelet aggregation. Once you get that platelet aggregation, we end up getting full occlusion of the vessel, and therefore the myocardium no longer gets the oxygen that it needs. So when we look at high-risk population, we have to understand that we have to look at the people that have atherosclerosis or are more likely to have atherosclerosis, and then also the ones that fall into a triad known as the Valkow's triad. Now, the Valkow's triad is any condition that brings on an increased probability of clotting cascade occurring. So that is the presence of endothelial damage, stagnant blood flow, and states within the body that cause hypercoagulopic states. Now, when we look at the first couple, we have diabetics, that's a decrease in blood flow, and also an increase in the probability of endothelial damage. When we look at our hysterectomy and post-menopause, that's got to do with people that are associated with that hypercoagulopic state. Obesity is highly associated with hypertension and hyperlipidemia, and smoking causes increased free radical causing endothelial damage. Sedentary life means your heart isn't used to working hard. Therefore, if you ever increase the need of the heart, just like any other muscle that's not used to be working out, it gets fatigued easy and is more likely to suffer the effects of low oxygen. Now, rural population are more at risk of acute coronary syndrome for a few reasons. One, associated with them actually seeking help, availability to decent healthcare, and then in the event that myocardial infarcts occur, their distance in which they need to travel in order to get definitive care. Now, we'll talk about a few timelines and key milestones, if you will, for evacuation priorities as we go along, but rural population definitely fit into that group. And as to, do we, when we're in the actual field and we need to evacuate someone to a high care facility. So when we look at the assessment of acute coronary syndrome, we need to look at three main things. Now, two of those things have to be present in order to have the diagnosis. Now, the main one is clinical symptoms and history. Okay, believe it or not, that is your main one that you can go for. So you can use pure gestalt to feel that someone's having acute coronary syndrome, myocardial infarct, and then you can literally evacuate them just with that, nothing else, no other positive signs needed. Okay, but before you evacuate them, a 12-lead ECG needs to be done. You also need to be aware that 50% of patients presenting with active acute coronary syndrome won't more ECG changes, and this is just because it's too early for there to be cellular changes within the myocardial sites in order to show up on the ECG. So don't use the ECG as your absolute definitive. Now, cardiac biomarkers like creatine kinase and troponin are extremely useful when aiding with diagnosis, but they do not replace an ECG. Now, we have in the system, we have istats, and istats are capable of drawing troponin, but for some reason, a lot of the times we go out to major exercises and we don't take istats, we don't take cartridges, and we don't take means of holding on to those cartridges. So keep that in the back of your mind that cardiac biomarkers are a key in the diagnosis of a lot of these acute coronary syndromes, myocardial infarct, and realistically we should be carrying them considering we absolutely have them. Now, when you're looking at the big clinical symptoms, just be aware that there is something known as a silent infarct. Okay, so 40% of those, especially the inferior infarcts that are happening, will not present with that classic chest pain, central crushing chest pain, but they'll actually have strong signs of shortness of breath and hypoxia as well as hypertension. Okay, so they have signs of shock. So look out for those ones. They feel terrible. They have the associated feeling of myocardial infarct just without the pain. So if you see these ones, think it could be a silent NMI and put a 12-lead ECG on them. Now, when we have a look at the PCCM, it has this division in the way it breaks things up, in the way it talks about different things and gives you a bunch of options in what you can do. So everything is essentially falls under this coronary ischemic syndrome, and that's the way they define it. So all of the ones that we've been talking about fall under this coronary ischemic syndrome. Now, that can be broken up into stable angina. Now, they're the ones that people know they have angina. They do a little bit of exercise, they get the chest pain, they stop exercising, and it goes away. Okay? Or they get a little bit of increased need for oxygen, they take a dose of GTN, and it goes away fully, no problems at all. So that's that stable angina. But then we can move into what we're actually talking about now, which is acute coronary syndrome. Okay, and that fits in the umbrella of including your ST elevated myocardial infarcts and your non-ST elevated acute coronary syndromes. Now, those two can either be broken up into your non-STEMIs or your unstable angina. Now, the difference is, in all this category, is a combination of how much occlusion the coronary arteries have compared to how much oxygen need is required for the myocardial. Now, a lot of the time there's no hard and fast rule of, 80% occlusion means you're going to have a non-STEMI, 95 makes you a STEMI. It's different for each individual. Now, sometimes your unstable angina is caused by minor aneurysms. I mean, you've got leaking of actual blood in the coronary arteries, meaning oxygen's just not getting there. So it can be a number of different causes, but we look for changes in the ECGs and we look for characteristics from there. So when we talk about acute coronary syndrome, I include all STEMI, non-STEMI, unstable angina in the one mix, and the treatment for them is the same. So we'll start with looking at the pathophysiology of your acute coronary syndrome. Okay, so as I mentioned, a lot of the time it is caused by atherosclerotic heart disease. Okay, but it can obviously be caused by an emboli or a thrombosis. But in the event that you just have decreased blood flow, either individually in the case of aneurysm or systemically in the case of shock, you can still have the same physiological effects associated with the myocardium. So as soon as the myocardium doesn't get enough oxygen, you start forming myocardial ischemia. Now this is the same as any muscle in the body. Now obviously the heart constantly works, constantly beats and contracts all day, every day. So it uses a huge amount of oxygen, huge amount of energy, and it is highly susceptible to hypoxic states. So once you start to get that hypoxic state, then you get myocardial ischemia, meaning lack of oxygen. Now this is a result of a decrease in oxygen supply, which will in turn cause an increase in cellular hypoxia. Okay, so the actual cellular level is not getting enough oxygen. Now what that means for the individual cell is that cell is going to have to start working anaerobically. Okay, now that is a massive problem for the heart. The heart does not like to work anaerobically, and you end up getting your cell membrane disruptions. Now, taking it right back, and I won't dwell too much on it because there's plenty of lessons in the past, but obviously when we're dealing with the cell membrane of the myocardium or the heart, we're hugely dealing with action potential, resting membrane potential, and the need for the constant changing of ions, especially sodium, potassium and calcium. Throw magnesium in there for good mix, but these ions are needed in order to transfer, in order to create what's known as a gradient shift and a dissociation, in order to have what's known as the Ohm's law of drift, in order for the electrons to move from one side to the other. Now in the event that we do not have enough energy being produced because the heart is required to work anaerobically, then you are going to have a problem where potassium is leaking out, sodium is leaking in, which is your normal physiological state, but in the absence of energy, you will not be able to utilize the potassium-sodium pump in order to exchange it to take it back to your normal resting membrane potential, which means a lot of the times the sodium will stay inside the cell and the potassium will stay out because you do not have the energy to waste, because you need that energy for contraction in order to stay alive. Okay, you'll also lose your automaticity, which is something else. But the biggest problem with that is because now you've got sodium in, and sodium has such a larger osmotic draw than potassium, then you are going to draw fluid into the cell. And the cell is going to get large, obviously fat, and sometimes that cell can burst as a result of it. So just to set that message home, when we have a normal state of a happy cell or a happy neuron at rest, which is what the myocardial represents, so you have a high intracellular potassium, a low intracellular sodium, and low intracellular calcium concentration. So this is maintained by active transport, because if it wanted to be normal, you just have equal areas across the actual membrane. So the most rapid effect of hypoxia and a shortage of ATP is associated with normal ionic gradients across the membrane, which means you have a rapid infusion of potassium from the cell and movement of sodium and calcium into the cell. And this is where we get a lot of our ECG changes from. Now after all this is said and done, the shortage of ATP, the lack of proper functioning action potential means you're going to have a decrease in myocardial contractility in that actual area, which is obviously going to decrease output and arterial pressure. Now this will cause the body to obviously do what the body does, and therefore the body will be stimulated in the baroreceptors that you have a low blood pressure, and that will stimulate a sympathetic response. So the release of adrenaline, release of noradrenaline will increase peripheral vasoconstriction and myocardial contractility, which in turn will increase afterload. Now, whilst this sounds good, and normally it is a good thing when you have a decrease in blood pressure, this kicks in, okay, nice and quick, but in the case where the tissue isn't getting perfused, then all you're doing is, in turn, you are increasing the need of oxygen, decreasing the availability of oxygen, which just further increases the myocardial oxygen demand and further increases the myocardial ischemia. Okay, so the body's own inbuilt protective mechanisms of increasing perfusion in order to get more blood to the area, which would normally be perfect, but now you've got an area of the heart that can no longer contract because it's not being fed oxygen, therefore not having enough energy, and you're not allowing the actual heart to fill to its full capacity, which means you're not getting the most out of it. Trying to increase the contractility of the heart, which increases oxygen demand that can't get there. Okay, so that is what happens when we're dealing with myocardial pathophysiology, and this continues until you get to that point of time that you go from ischemia to infarct, and then that's it. There's no electron movement, it's just dead. It doesn't function at all. Okay, so that's why we get early on our management and we start the treatment as quickly as possible, and evacuation is the key. So if all these problems have started from a lack of oxygen, it makes it very easy to see why a lot of people, especially in the past, jump to the conclusion of saying oxygen was the best answer. But when we look at oxygen and what oxygen actually does in the body, we realize that it's not just the sheer presence of oxygen that makes things better, it's a balancing concentration of oxygen that actually makes things work. Okay, now obviously you need oxygen. You absolutely need oxygen in order to produce the right amount of energy, in order to allow things to energy cycles to continue right through to the end. Okay, but the presence of oxygen initially can be a problem. Now the reason it can be a problem is because of the associated build-up of free radicals. Now free radicals can be formed in a number of different ways, but their damaging presence usually is a result from the absence of oxygen, which in normal physiology is at the final resting place of the electron flow. Now the electron flow is obviously talking about the myocardial electron transport change. Okay, when oxygen is missing or diminished, these electrons build up and they just bind to other carriers. And these carriers are unable to pass the electron on, therefore causing a problem. Now, the most well-known molecule associated with the formation of these free radicals is your nitrous oxide. Now, under normal circumstances, when you have nitrous oxide, it causes vasodilation. No problems at all, and that regulates blood flow. Okay, nitrous oxide can accumulate in high concentrations, and it can react with other free radicals, thereby setting up two mechanisms of cellular death. Okay, so when you have a little bit, it causes vasodilation. When you have a huge amount, it's associated with cellular death. And those two are from oxidizing injury and energy depletion. In the event the mitochondria is affected, it loses their membrane potential, and high concentrations of nitrous oxide and ATP is essentially halted altogether. Now, as a result of no ATP being produced, then it leads to further endothelial damage, which just increases the inflammatory state. Okay, so that's what's happening at the top half of this particular picture, just to give you a full information. Now, I might have got a little bit too excited and delved a little bit too deep, so just take it back. Nitrous oxide is built up with other free radicals in the absence of oxygen. When you introduce oxygen to the equation, then you start to remove these free radicals. Okay, these electrons can be passed through the electron transport phase and things start to get better. But in the event of myocardial infarct, if you give too much oxygen, okay, you're giving too much oxygen straight away or high concentrations than the body actually needs straight away, then you kick in to your other blood pressure regulators, so your angiotensive systems. The oxygen will allow your angiotensive to go from a state of vasodilation, which is caused by nitrous oxide, to a state of vasoconstriction, which is absolutely not what we want, because that causes vasoconstriction of the coronary arteries, which decreases blood flow to the heart further and therefore delivers less oxygen. Even though there's more oxygen in the system, the vasoconstriction means that there's less oxygen. But systemically, it also reduces stroke volume and cardiac output because of the vasoconstriction. You're not getting that flow coming into the heart. Okay, now we'll talk a little bit more about that with GTN, but that happens as a result of oxygen. So the secret is you want to give them oxygen, but not an abundance of oxygen. And that's why in the presence of studies and everything that they've done, they've decided that if someone's at 93, 94, a lot of studies, a little bit of argument there, but that's close enough. If they're at that 93, 94%, then they do not require supplementary oxygen. If they're under that percentage, then you give them oxygen. And you give them oxygen through nasal prongs. Okay, you don't give them a non-rebreather, 15 litres, blow their head off. You give them nasal prongs, and you start at 4 litres, and then you wind back to 3, to 2, and then you watch your actual O2 sats, and you go from there. Okay, if you have an O2 sats sitting at 95, then you can leave it. Don't have to drop it back. If you put on 2 litres and it goes straight, 4 litres and it goes straight to 98, then drop it back to 2 litres. Give them as much oxygen as they need. And their treatment for myocardial infarct will actually be improved by being a little bit reserved with your use of oxygen because of the physiological effects I just spoke about. Okay, the ECG. We put oxygen on, now we have to give an ECG. Now ECG, we can look for changes. Now we're not going to go into a great deal of detail in this lesson on changes within a 12 litre ECG. I'm just going to introduce the concepts of anterior-septal, lateral, inferior, and what coronary arteries they're associated with. That's it. So looking at the picture here, if you need to, keep a picture of it, get one of those cue cards, because as we move on, we're going to look at the different coronary arteries that affect each one of these areas. Okay, so they're the areas. Okay, mostly anterior-septal, a little bit of inferior. Now when we look at inferior infarcts, we are dealing with, it can be your right coronary artery, but it can also be your left crucifix, okay, artery, because that travels around the heart, and we'll see a picture soon. So the inferior side is the best view we have doing a normal ECG on the right side of the heart. Okay, so with an inferior, there's a couple of things that ends up into play, so you need to be a little bit careful with the use of GTN. And this is also where you're encouraged to do your leads 7, 8, 9 around the back, or going V4 right is when you're dealing with inferior changes. So lead 2, 3 and AVF for inferior. Okay, but I digress, so I'm going to move on now before we start talking about more things associated with ECGs. So we'll look at the heart, okay, and we'll look at the actual coronary arteries. So the main ones at play that we look at, especially with the ECG, is your right coronary artery a little bit. Your main one is your left coronary artery and its bifurcation, the circumflex coronary artery and the anterior descending coronary artery as well. Okay, so they're the ones that we are mostly looking at, especially when we are dealing with your lateral and your anterior-septal problems. So just as a few examples for you, we can see ECG changes here. So this is what's known as ST elevated myocardial infarct of your anterior-septal and anterior-lateral leads. Okay, so this is what occurs when you actually get a high left coronary artery occlusion. So right at that bifurcation, you get an occlusion there. You'll get the anterior-septal. Sorry, 1, 2, 3, and 4. Okay, you see the ST elevation from the actual ST segment raising above the isometric line. Okay, and then your lateral is where you look at your 1, your AVL, and your 5 and your 6. So you'll also see ST elevation on those leads. Okay, so when you see a heart that is in ST elevation across most leads, then you're dealing with what's known as an LCA. Just wanted to show you this anterior-septal, anterior-lateral one. And we'll move on to the rest of the management of acute coronary syndrome. And we'll start with our aspirin. Okay, so aspirin is given to everybody that shows signs of myocardial infarct or acute coronary syndrome. Okay, everyone that has acute coronary syndrome, you will actually give your aspirin to. Whether they're on aspirin, whether they're on warfarin, it doesn't matter. Okay, now we give 300 milligrams, okay, which is considered low dose. Now, aspirin is a non-specific COX enzyme inhibitor. Okay, but at low doses, it's mostly associated with blocking COX-1. Okay, and what COX-1 does is it interferes with prostaglandin like the CRX blockers do, and it ceases platelet aggregation. Okay, so that's the main thing that it does. So it actually stops platelet aggregation from occurring. Now, if you give high dose aspirin as opposed to low dose aspirin, then you run the risk of block COX-2, which can interfere with a different pathway which will cause your vasoconstriction. So, recommendation, 300 milligrams has been for a long time and is 300 milligrams in PCCM 10th edition. So that's why we give that dose when if you have a migraine or something like that, you can give up to 900 milligrams aspirin as your standard dose. Okay, so low dose aspirin is what we give, and this is the reason why it is 300 milligrams. Okay, the other medication that we give is obviously GTN. Now, GTN works in a number of different ways. Now, if somebody has chest pain, okay, and you're not very good on ECGs, all the rest of it, then you give GTN. Okay, that's what your protocol says. There's nothing in your protocol that says, oh, don't give GTN if you're showing inferior myocardial infarcts, ST elevation, or anything like that. Okay, it's just what certain higher studies and ongoing managements will consider. But for on the ground management, if someone has signs of angina, okay, so they have angina pectoris, physical signs of it, and that's what you're treating them for is acute coronary syndrome, then you will give them the GTN. You can either use the sprays underneath the tongue, or if you're lucky / crazy enough to carry the tablets, then you can obviously give those as well. So the spray is mostly the way that we go. Now, it does two things. Obviously, it dilates the coronary arteries. Now, those effects are obvious. Okay, it increases the oxygen supply to the area. So hopefully bypasses the atherosclerosis, bypasses the clot formation that's there, that's causing the pain, and allows blood to go over the top and actually feed the heart. Okay, but on top of that, it actually dilates the actual arteries around it as well. So it dilates the veins and it dilates the collateral areas, which in turn reduces afterload and reduces preload. Now, a lot of the times, this can be a horrible thing. Okay, so the reason we have preload and afterload is obviously to maintain perfusion. Okay, but in the event of acute coronary syndrome, the heart is working really, really hard. Okay, really hard. And the more you ask the heart to work, the more oxygen the heart is going to need, and the more of those pathological changes that we spoke about before are going to occur. So the beautiful thing about the heart is it is highly regulated by pressures. Okay, so we'll just talk about afterload initially, and to make it easy for everyone, we'll talk about the left ventricle, because afterload is associated mostly easily anyway with the left ventricle. So if the aorta has a huge amount of pressure built up into it because of vasoconstrictions and backloading or congestion or whatever it is, doesn't matter, got a huge amount of pressure, then the heart is going to be forced to contract to generate a pressure higher than that afterload pressure in order to have output. Okay, so to put it in blood pressure speak, if you have a blood pressure of 140 systolic, then roughly speaking, for simplicity, you're going to have to beat at a force that generates greater than 140 in order to actually have output. Now, the way that the heart does that is it increases the amount of blood that allows into the left ventricle, causing the walls to stretch. Now, when the walls stretch, then it basically optimizes the contraction force and optimizes the amount of your actin and myosin heads that are perfectly lined up in order to generate the greatest force. Now, if you need to generate the greatest force, then you obviously need to have a lot more ATP, which means you need a lot more oxygen, which is the problem associated with acute coronary syndrome. So by reducing the afterload, you are reducing the work on the left ventricle. Now the preload is pretty similar, okay, and this is where our good old Frank Starling comes into play, because this is more associated with stretch fibers. So when we're looking at preload, the preload side of the house is more associated with the more blood that comes in, the more force is going to be generated, okay, because of the same reason we spoke about before. Now, there is obviously a limit to these stretch walls. That's why we have a fibrous pericardium, so we can't just keep stretching and bulging out. So if you had a massive preload, then there is still a limitation, but by decreasing preload, then in turn you can have a reduction in how much that side of the heart is working, therefore saving energy, just reducing the overall decrease in the need of oxygen and ATP. Now, obviously, there is a limit, and this is why we check blood pressures. Now, even though the PCCM isn't explicit in checking blood pressures before giving GTN, it is still a very, very good clinical tool to do, because if you get to the point that you drop the blood pressure too far, that your decrease in afterload and decrease in preload comes at the expense of perfusion to the rest of the body, including the heart, then obviously it is a problem. Okay, so that's why we look at the contraindications, and that is why we always check a blood pressure before giving GTN. Now, we give 3 doses, but by the end of it, people can be put on GTN infusions, things like that, in order to maintain a state, if you will. Okay, and the last point of acute coronary syndrome, last treatment, is something that we should really start getting serious about, okay, and that is looking at our antithrombolytic options, okay, or even our anticoagulated and our thrombolytic options, okay. So right now we have an antiplatelet, for lack of a better word, okay. It stops platelet aggregation, and that's aspirin. That's it. That's what we carry in the treatment teams, okay. Now, in clinical speak, before we evacuate to definitive care, or before we put them on a regime, if we've got a long transfer, which we'll talk about, an aspirin is pointless, absolutely pointless. Okay, these regimes require an anticoagulant. Okay, now that inhibits further production of fibrogen. So things like heparin will actually stop your factor 10 and your thrombin from forming, and therefore reduce the formation of fibrogen. Okay, warfarin, we don't administer it, okay, but it is an anticoagulant, and that just interferes with the vitamin K side of the house, so that stops it. So you can go your heparin, or you can get your fractionated heparins, okay, like your enoxaparin, your clopidogrel, things like that. Okay, so that's your anticoagulants. They stop new clots from forming. Now your fibrinolytic or thrombolytic therapies, they actually promote lysis of your fibrogen. Okay, so the way they work is there's an enzyme in the body called plasmin, and that comes from your plasmagen, and that is used in order to break down fibrogen itself. So it's used if a clot gets too big, you don't need it. Normal state, this sort of blocks it down. Okay, so what your fibrinolytic does is it actually increases the amount of plasmin that is available. So it stops anything from blocking it, therefore increases its production, and in turn allows it to break down the existing clots. Okay, now with that, if any new clot was to form, it naturally just breaks it down straight away. So it is more effective on new clots than it is on old clots, which is why there's a limit with these. So the limit's usually associated with 12 hours. If you've had clots formed for more than 12 hours, then there's no point in all giving them. Okay, so there's also a general rule out there that if it's less than 15 minutes, then you don't give it because the body can probably take care of it itself, but depending on your protocols that you work with. The point is once it's on board, then you have a huge risk of bleeding. Now the other treatment, and the gold standard, is your PCIs. Okay, now this is where your angioplasty comes in. Now we can also move into the bypass side of the house. Okay, so your two main treatments is your fibrinolytics versus your PCI. Okay, but either way, patients in our situation need to be evacuated to a higher facility of care. So to finish off the importance, you need to get them evacuated as soon as possible. Okay, so that finishes the management and everything to do with acute coronary syndrome. I hope you got something out of it. From here, you really need to practice acute coronary syndrome, and don't fall for the old boring acute coronary syndrome. Actually start thinking about the management. Challenge each other with different options of what you would do in different environments and what would provide the best care. Okay.